Hi, this is Kathy Kennett, Senior Vice President of Clinical Care with Parent Project Muscular Dystrophy. Thank you so much for joining our webinar today. The title of the webinar is Adult Duchenne Pulmonary Care and Challenges. As I'm sure you all know, you are in muted mode. If you have questions, if you can type them in the box in the bottom left-hand corner of your screen. We'll try to get to the questions at the end of the webinar, but if it looks like there are pressing issues or confusion, we'll interrupt the speakers to address those questions as needed. I'm extremely happy to be joined today by Dr. Christina Mikesell and Dr. Lisa Wolff, both of whom are pediatric and adult pulmonologists in caring for Duchenne patients. Dr. Christina Mikesell is a pediatric pulmonologist at Children's Respiratory and Critical Care Specialist in Minnesota that wears two pulmonary hats. She not only specializes in the care of children with neuromuscular diseases, but has the pleasure of following them throughout their life and taking care of adults with these conditions as well. She's one of the few pulmonary providers in the state who's responsible for the care of patients at children's hospitals and clinics of Minnesota, Minneapolis, and St. Paul, Gillette Children's Hospital, Gillette Lifetime Adult Care Center, Regents Hospital, and Essentia St. Mary's in Duluth, Minnesota, and as the Pulmonary Aerodigestor Program Director at Gillette. She's a little busy. She is passionate about the care of patients with neuromuscular diseases so much that she's gladly extended her expertise to adults to help fill a significant care void in the state. Dr. Lisa Wolff is Associate Professor in Pulmonary and Clinical Care Medicine and Neurology at Northwestern University. She's Director of Respiratory Care at Shirley Ryan Abilities Lab, the hospital previously known as the Rehab Institute of Chicago. She has published and spoken extensively to audiences around the globe, expounding on both research and care of pulmonary issues for people living with neuromuscular disease. Her area of research and interest focuses on home-based respiratory support, and specifically in the areas of airway clearance in both invasive and non-invasive ventilation. Lisa, I believe you're first, so I'll let you take over.
Thank you very much, and thank you to Parent Project for putting this together. I'm going to dive right in since our time is short. We are going to be talking today about adult challenges in pulmonary function for those living with Duchenne muscular dystrophy. That transition from childhood to adulthood is very important. We worry a lot about something we call falling off the cliff. There should be a smooth passing of the baton from pediatric programs to adult programs, but frequently those relationships are not so clear, and patients can have a loss of care for a time. It's also important to plan for these transitions to support patient autonomy, and when successfully done, this can have a significant impact on patient mortality, prognosis, and outcome. We'd like to take the opportunity of the transition from pediatric to adult care to talk about taboo subjects like issues of end-of-life and sexuality and what does independence look like. Our goal is to empower our patients and put patients in the driver's seat rather than their parents. These areas are significantly impacted by lung and lung health, and so we're going to jump right into that. We know that in adults there are predictable watershed moments. These are moments where we have what we call the unpredictable yet predictable unspeakable moments. Those focus on the need for formal ventilation or 24-hour ventilation and episodes of life-threatening pneumonia. And so because of that, we will focus our care mostly on airway clearance and ventilation. We want our patients to see adult providers as opposed to pediatric providers so that we can help to generate autonomy. We can talk about adult issues. We can deal with the inevitable insurance changes and how that affects care. And we can discuss future respiratory needs that were not necessary in childhood, especially parasurgical issues, because we know in adulthood our patients are more likely to need surgeries, such as kidney stones or gallstones. What kinds of adult pulmonary providers will our patients need? Well, first of all, they'll need a pulmonologist to be their team leader, and at best, that pulmonologist should be part of an integrated multidisciplinary neuromuscular team where all players for care are sitting together and working together. Patients frequently will need a sleep specialist in addition to their pulmonologist. And they should also have a home-based respiratory therapist to assist with any care needs in the home. In general, when we talk about what we do at a first visit when we are transitioning from pediatric to adult care, we talk about what's called a head survey. HEADS, and you can see on the slide in front of you the different areas that are reflected by our head survey. And what I have suggested here is different areas in which the pulmonary component is very much prominent. Specifically, if a patient has a living situation such as a dorm or a first apartment or community integrated living arrangement, is there a place there for non-invasive ventilation? Is there support for airway clearance? When our patients make educational decisions, the availability for support around these things becomes very important. We also want patients to concentrate on exercise, especially range of motion for their chest wall. We'll talk about how to get that. We'll talk about how respiratory issues may impact their ability to get out of the house, get to activities and class, and how those issues of shortness of breath may impact daily activities, talking about things like going to class, having sexual relationships, or even having to do activities that may be common for other patients. We talk about the role of getting dental care to prevent pneumonia. We talk about the role of diet to reduce the risk of bone fractures, because bone fractures can become a risk for the lungs, believe it or not, if you have to have surgery to have them fixed. And then last of all is sleep. And we know that circadian issues or body timing issues can impact sleep, and if you don't get enough sleep, you're not using your PAP as much. By the way, the Empowered FIFIs that I reference here under the sexual issues is a local group here in Chicago that helps patients with disabilities deal with these issues. Transition of care from childhood to adulthood breaks down into two parts, ventilation and airway clearance. The first thing that we do is to look at a patient's current ventilatory strategy. The vast majority of patients who have Duchenne muscular dystrophy will already be on a form of non-invasive ventilation prior to the transition to adult care. With the newer medications, occasionally that's not the case. But what we do recommend is that at a first visit, there should be a download of the PAP device to review mask fitting, to review compliance, to look at breath size and frequency, and to make sure that the PAP therapy is appropriate, the right device is being used, etc. The next thing that the physician should do is to review an airway clearance plan. Your airway clearance plan will break out into two sessions, one looking at lung volume recruitment strategies and another looking at secretion clearance. Lung volume recruitment talks about daily exercise to expand the chest wall, completely open the lungs, and the secretion clearance talks about getting rid of any secretions if they exist in the chest and the nose. In order to assess how much therapy for these two areas is necessary, the clinician should start by ordering lung function tests. The most prominently utilized lung function test is called the spirometry test. Spirometry tests look at the lungs. Here you'll see on this picture is the diaphragm. That is the muscle that generates breath. So the problem is not with the lungs themselves, but the insufficient muscle strength to generate a breath. For adults, it's very important that we get portable handheld devices, such as you can see in this picture, and that you try to avoid devices like this that are called body boxes. Those body boxes are difficult for patients with Duchenne because you would have to do independent transfers. They can't hold a wheelchair or power chair, and it would be very difficult for our patients to get necessary treatment unless they're using the appropriate device. When doing the test, you will see that the older you are, the more likely you are to have abnormal lung function. And those who require a wheelchair are also more likely to have abnormal lung function. When looking at lung function, we want to see the difference between how you breathe when you're sitting up and how you breathe laying down. And you'll see in this graph here, we look at the supine fall, or the fall in lung function when you get on your back, compared to the strength that the muscle has to generate force when you're doing a sniff maneuver, sniffing in as hard as you can. And what you'll find is that if you do not have significant equivalent lung function between upright and supine, it's a sign that the diaphragm is very, very weak. And you'll see here that in the supine position, those that have the greatest fall have the most weakness in their diaphragm, such as those that have these open circles. So the next thing that we would look at would be the difference in how patients' lung function changes with age. Now, this is specifically data from Becker muscular dystrophy, but a similar pattern holds true in those with Duchenne muscular dystrophy. Just because we know someone's genotype does not mean we know how their phenotype will work. And if you'll look, and this is just an example of pairs of twins who have the same gene, and then looking at their lung function across the years. And you'll see here that lung function peaks at about 18 years of age. And you can see that at that point it is either high or it's low. Those that are high at 18 years of age tend to consistently stay high as they get older. And those who have lower numbers at 18 years of age will have a decline that's more rapid as they get later into adulthood, which is why at the transition appointment, getting lung function testing is so important. In addition to doing the spirometry test, we also like to get a force generation or a maximum inspiratory pressure measurement. We like to see these values at greater than -100. That would be normal. And we know that in the U.S., the value is typically generated this way with a mouthpiece and a device that will measure how strong you can suck in. In Europe, they use a nasal interface, as you can see in this diagram. This, with a nasal interface, is called a SNP. If it's here with a mouth interface, that is often called a MIP, M-I-P, or maximum inspiratory pressure, but these are essentially measuring the same thing. It's looking at force generation rather than volume, the way we look at with the spirometry test. Why are these numbers important? Well, if for no other reason, because it helps us to determine when it is time to start non-invasive ventilation. Non-invasive ventilation with mask ventilation and a PAP machine became widely available somewhere between 1990 and 1993. By 1995, especially in the U.S., Medicare had noted a significant increase in the number of devices that were being used, and so they assembled a group of experts in 1998 to give them significant direction on how to provide these devices appropriately. Patients with neuromuscular disease were put in what is called the restrictive thoracic disorder criterion, and these are listed here. In a patient who has neuromuscular disease, any one of the following is enough to qualify them for the initiation of non-invasive ventilation. An increase in their CO2 to 45, a decrease in oxygen level during sleep, which is less than 88 for greater than 5 minutes, or a forced vital capacity, and that's either upright or supine, of less than -50, or a maximum inspiratory pressure of -60 or greater. You can see there are 4 options here by which someone could qualify. And what you'll see here is that for those patients that are adults, polysomnography is not mandatory in order to qualify for non-invasive ventilation. That being said, we feel that measuring those values is not enough, because although it helps us to understand when we need to initiate non-invasive ventilation, it doesn't tell us all we need to know about airway clearance, which is the other significant abnormality that we're concerned about. To better measure that, we'd like to measure something called a peak cough flow, which measures how strong the person's cough is. We use this device, which is a standard peak flow meter, often used by asthmatics. The difference is that in asthma, the patient is instructed to take a deep breath and blow as hard as possible. In the setting of neuromuscular disease, the patient is instructed to cough as hard as possible in order to measure cough strength. Normal cough strength is greater than 500. Adequate is at 270. And those that are at 160 or less are at very high risk of having pneumonias and life-challenging events that may even require tracheostomy. We would like to intervene with cough function as you get to this 270 level so that we never have to worry about potentially life-saving episodes going down to 160 in those who may never have been treated appropriately. This talks about the relationship between cough and ventilation. What we know is that breathing and coughing start normally. The first thing that we notice as lung function drops is that there is a decrease in sleep-related breathing and an increase in CO2 that happens first during dream sleep and then during non-dream sleep. This would happen at approximately 40 to 50% of the forced vital capacity. What we try to do is intervene before this time so that we can buffer it and reduce the chance of having hypoventilation. We know at this exact same time cough is frequently impaired, and what you'll see is that forced vital capacity here in liters per minute directly is related to the pressure of cough generation. So when we find the abnormality here, we want to look for the abnormality here. The next thing that we can do is actually look for those CO2 levels. We can measure daytime CO2 using transcutaneous CO2 by doing blood gas testing or measuring end tidal CO2. We know that in those that have neuromuscular disease, small breaths or small tidal volumes may give us abnormal, incorrect values on end tidal. And so we prefer to have either the transcutaneous CO2 or the blood gas testing in order to see where CO2 is. And we know that these tests specifically can be recorded overnight to look for nighttime hypoventilation. Overnight testing comes in many different varieties. Commonly available is the sleep apnea test. The sleep apnea test can be done at home using small interventions such as this NOMAD or apnea link test. However, this only measures obstruction of the upper airway. It does not look at hypoventilation. It measures oxygen and respiratory effort, and sleep time is not measured, so mild patients can be missed. On the other hand, we can do transcutaneous CO2 measurements overnight that measure oxygen and CO2. Again, sleep time can be missed, and it does not look for upper airway obstruction at all. So neither of these tests is perfect for those that have muscular dystrophy. Instead, we perform full in-lab sleep studies, such as this one, that can screen for hypoventilation, upper airway obstruction, and desaturation, so that we can make a better effort not to miss any abnormalities. That being said, if the forced vital capacity is reduced in our patients, diagnostic testing may not be necessary. And we can go straight to PAP testing or a therapeutic study, increasing the speed at which we can treat our patients. So this is my list of do's and don'ts for in-lab sleep testing for those that have muscular dystrophy. Don't delay the start of non-invasive ventilation awaiting a polysomnogram because they can be very lengthy times to get into the lab. Don't order a sleep study unless the sleep lab has a protocol for those with neuromuscular disease. Don't order a sleep study unless the lab has physical accommodations for those with disabilities. And as patients, you must advocate for yourself and ask about these before starting any study in a lab. For instance, asking the lab, do you have a protocol for neuromuscular disease? Do you have lifts, hospital beds, call systems, etc.? And if they don't, either find another lab or find another way to be treated. And don't use a need for diagnostic testing to slow the time to start to a RAD, which is the same thing as non-invasive ventilation, if you have met the criterion. Now, once we've made decisions about non-invasive ventilation testing, Let's talk a little bit about lung volume recruitment testing and airway clearance. Remember, airway clearance breaks down into two jobs. One is to expand the chest wall, prevent atelectasis or collapse of lung segments, and then the other job is to help remove secretions. This is a very commonly used technique called lung volume recruitment with Ambu bag and breath stacking. This technique provides chest wall range of motion by increasing the volume of air within the lungs to expand the chest, the sternum, and the ribs. It improves cough by providing a bigger breath. For those that have a loss of lung function, it may also help to improve their speech by giving them a larger breath that can give more volume when speaking, and it can also help to improve their swallow function. For the swallow function, we're going to talk about that a lot more with Dr. Mikesell in a minute, but I would like to remind you that as you are aware, when you go to take a large breath in before taking a bite of food, the importance of that is that you must complete chewing and swallowing before taking the next breath in. If your breaths are too small, you'll be forced to take another breath in while you still have food in your mouth. And that can cause food to go down the wrong way, even if the muscle strength for swallowing is adequate. So we recommend doing this kind of Ambu bag or any type of lung volume recruitment exercise just prior to meals. It will help to keep a structured day, make sure that you get your exercise in, but also reduce scary episodes around meals. That Ambu bag and inhalational maneuver can be assisted with what's called a manual assisted cough. And you'll see here that a caregiver is helping to push in and up as the patient in the wheelchair is doing an expiratory cough maneuver. This will help significantly to augment the cough, not that the patient is unable to take themselves, and I'm going to show you just how much here in a minute. If a patient cannot do an Ambu bag for breath stacking because of issues with coordination, weakness in hands, or availability of the device, the alternative is something called a mechanical cough assist machine, like the two that are featured here. And what happens is you'll see that there's one pressure for exhalation, one pressure for inhalation, and it mimics a natural cough by providing inhale, pause, and then exhale, just the way your regular cough would, helping to both expand the lungs, prevent atelectasis, but also suck out secretions. And these secretions can be sucked out both from the nose and the chest. The device that we have for cough assist devices is not commonly available in hospitals. Because of this, patients with muscular dystrophy should bring their own devices when they go to the hospital. But it has been well demonstrated that the use of the device helps to prevent the need for tracheostomy, reduce death from pneumonia, prevent hospitalization, and improve lung function by reducing atelectasis or lung collapse. Typical settings for the device are summarized here. And for adult patients, we would look at having levels of about 35 to 40 with inspiratory times at each phase of about 1 to 2 seconds. And it can be used either with a mask, a mouthpiece, or a tracheostomy tube. And when compared directly, we know anyone who gets the abdominal thrust, which is that manually assisted cough, does better than someone who just does an unassisted cough, even if they're coached. And we know that the addition of breath stacking or any positive pressure device, like a cough assist or an Ambu bag, gets the best results. That being said, within this red group here, each individual patient performs better on an individual device, and suggesting that all therapies are best when they're individualized. Hospitals can now provide alternative treatments that include something called a metaneb. The metaneb offers both pressure and vibration to help both liberate secretions from the sidewall and help them to be coughed out. Hospitals also could provide something called a therapy vest during acute exacerbations with pneumonia that are going to provide increased shearing forces to help liberate those secretions so that they can be more easily coughed out. And in new data that was published by our group about a year ago, it's found that those patients with neuromuscular disease who were prescribed a therapy vest or a high-frequency chest wall oscillator had fewer admissions and less pneumonia after being prescribed the device. We recommend that patients using airway clearance at home have a suction unit like this one, and sometimes deep suctioning is needed, and that can be enhanced by things like this, which is called a no-bite 5, or by the use of different kinds of flexible catheters. In summary, I'd like to remind you of this very important box here, which is the Lancet published guidelines for the care of patients with Duchenne muscular dystrophy, which was facilitated with Parent Project. The spirometry should be done twice a year. Immunizations should be reviewed yearly. Lung volume recruitment maneuvers should be done with those with a forced vital capacity less than 60. And a cough assist device should be started at a less than 50, a peak flow less than 270, or a maximum expiratory pressure of minus 60. And all of these are effective times to initiate non-invasive ventilation. These are key transition times from pediatric to adulthood. It's time for us to emphasize lung function testing, airway clearance, and review of our strategy for non-invasive ventilation. So my time is up, and I'd like to thank you all and pass my baton on to Dr. Mikesell.
Thank you, Lisa. So first off, I would like to say thank you to the PPMD and to Kathy Kinnett for inviting me to speak today. I would also like to say I am sorry in advance, just in case my phone gets cut off. I am mixing business and pleasure, and I'm in tropical Wisconsin Dells with my boys, and I think half of the country is here, and they're all using their cell phones, and my cell phone service is sketchy at best, and I've already been disconnected once. So if I get disconnected in the middle of this, I will get relogged in as fast as I can and hopefully get unmuted so everybody can hear me again. But hopefully I'll make it through without any glitches. But just in case that happens, everybody hold on and I'll call back as soon as I can. So I get to discuss three topics that, at least with the patients that I take care of, are three of the least favorite topics that we get to bring up in appointments. Because there are three milestones in the disease process that are milestones, but not positive milestones when we consider them, but are things that are very important to talk about and are very important things for patients to have an understanding about and also to be aware about and know what to be looking for and what symptoms to be watching for and when things to be watching for in themselves prior to these being discussed with their physician. So the first is swallow dysfunction, or dysphagia, as us doctors like to throw around. So swallow dysfunction is common and is most frequently progressive in our patients. In a study done of a mass population of Duchenne's patients, about a third complained about choking with eating. And I would say that is a number that's early in the Duchenne process and then becomes much more common later in the Duchenne process. It's most common once the patients are not able to walk, so non-ambulatory, but occurs in patients who are able to walk as well. And at first, it can happen when the person is fatigued, both from an eating standpoint and also just from a general fatigue standpoint, or it can appear only with illnesses at first, as illness process makes a person more tired. It can occur with solids and or liquids, but most often starts with difficult solids such as meats. And I have to say steak is pretty much the bane of my patient's existence. And then it also can occur with dry solids like crackers and bread. It can lead to weight loss before the diagnosis is made, which we often see in our patients. There are subtle signs at first, and so I think these are important to discuss because these are things that people can notice at home, both the patient and the family. So longer meal times. A lot of times I'll ask my patients and the families, is it taking long to get through a meal? For my younger patients who are still in school, They'll notice that we're not finishing our lunch at school, and more food is coming home, or we're losing weight, and we think it's because we're eating less at mealtime. Different food preferences, so we're becoming a pickier eater. That is a complaint that we'll hear. Chronic throat clearing becomes a problem, or chronic cough. Very mild, subtle thing, but it'll get noticed. Sometimes it's not even noticed, and it's something that I'll pick up in the office as I'm chatting, that I'll hear them clearing their throat. Or a raspy or wet-sounding voice or breathing is noted or picked up, and this is a slow, progressive process. More frequent or prolonged or severe respiratory illnesses. So it was a person who used to be previously really healthy, and illnesses now are becoming more of a to-do. They're lasting longer. They're more significant. They're becoming more severe. Or we're getting sick more often. Things that didn't used to cause us a problem are now causing a problem. Or these illnesses are turning into bronchitis and pneumonias. Or we get a single big pneumonia. It can cause chronic inflammation in the airways or seeding of oral organisms. Our mouths are filthy, filthy places. They always say our mouths are dirtier than dogs' mouths, which I think are gross when you see dogs eating poop. But our mouths can seed from aspiration, our airways, and you can get oral organisms that seed the chronic inflammatory changes in the airways, and then that can lead to bronchitis and pneumonias once you get a viral infection. So it's not that our patients are diagnosing themselves from the internet, but many of my patients who come to me already know that they're having trouble with their swallow, and then it's more that they come to me and they know that I'm going to suggest that there's probably an issue with their swallow and diagnose them with a test, and that the test is actually going to tell us not that there's a problem, but how severe the problem is. So one of the most common tests being used is a video fluoroscopic swallow study, or a video swallow study. A VFS is another word for it, and these are the images that we see. And what it is you drink liquid barium at range of consistencies or eat a range of barium-coated foods. And the swallow mechanism is observed on a live X-ray. The amount of observation is limited by radiation exposure, though. So often, fatigue effects are not seen. So early in swallow dysfunction, so if it's caught earlier than when it's terrible, you don't see swallow dysfunction or problems with the swallow until late in the feed when you have trouble with that fatigue effect. So the swallow starts getting fatigued, and then you start having that discoordination. And there's a problem catching this on the swallow study because we don't watch the whole meal on a swallow study because that's a lot of radiation. So you can miss that on a swallow study. And then you're going to hear us talk about residuals, penetration, and aspiration. And what that means is just basically where the food is getting hung up in the throat. The residuals is where it doesn't get to the supraglottic area, so the area above the vocal cords and the larynx itself. Penetration is when it gets into that supraglottic space but not past the vocal cords into the airway. Shallow penetration is an okay-ish thing. It means it's getting deeper in there, but it's not directly associated with aspiration. But deep penetration in medical studies has been associated with aspiration. So at our center, any patients who have deep aspiration or deep penetration, we consider that equivocal with aspiration. And then aspiration is when it gets through the vocal cords and into the airway itself. A FEES is a fiberoptic endoscopic evaluation of swallow, so that's what the FEES stands for. And that's where an endoscope is placed through the nose and into the nasopharynx, so the back of the upper part of the throat there. And so it actually watches your swallow mechanism with a camera, and you can see the picture there. And so this is what most of my patients look like when I tell them that I want to do this, and they actually are saying to me, you want to stick what, where? And I have to have a really good answer to them as to why I want to stick a camera in their nose and look at swallow instead of having them just eat something that is barium coated. And there is good reason why you want to do a FEES study instead of a swallow study in some patients. So it is a direct observation of the swallow with a camera. And there is a lot of information you can gain from actually observing the swallow live with a camera. One of the major things that you can do with this is you can monitor the swallow over extended periods of time because there is no radiation. So you have no danger of that radiation effect. So you can watch the swallow over a meal and assess that fatigue effect, especially when you have patients who are having an intact swallow at first, but you're really worried about that aspiration from fatigue. And aspiration is aspiration. It doesn't matter if it's early or late. If you aspirate, you aspirate. And so that aspect and that ability to monitor what happens over the extent of a meal is very important. You can also assess the ability to clear residuals of various consistencies, and there have been studies that have shown life-threatening events with delayed clearance of residuals even well after meals, and so it's very important to see what patients can do with those residuals if they're left hanging. You can assess the management of secretions, and if the secretions are difficult to see, you can actually add food coloring into a patient's mouth to color the secretions and see how they handle them. You can assess the efficacy of treatments in real time, and so we'll talk a little bit more about treatments in a little bit, but you can actually implement them and see how things go where that's limited with your video swallow study. And you can assess the effect of trach cuff volumes on swallow, which we'll talk about a little bit later too, but you can do real-time treatment, which is important in some patients. So treatment. So a lot of patients come to me once they find out that they're aspirating and they're like, what can I do? What can I do to fix this? Because I really want to eat. Eating is important. So the NMEs for short, so the neuromuscular electrical stimulation. This is where you actually use electrical stim pads on your neck in very specific locations to give electrical stimulation while you're swallowing in a training kind of stimulation. The research is inconclusive about this in patients with muscular dystrophy. Weakness in DMD may worsen with regular low-intensity exercise and thus weakening the swallow, so worsening it. And there's no consistent evidence to show that this is beneficial and actually can worsen the swallow. And then on that same note, strengthening training. I've had patients come to me outside of our center, because our center does not recommend this, who have been on the internet or in another center saying that they can do strength training. So studies overall are unable to state that strength training is of benefit and recommend, because of that fatigue factor, recommendations are for conservation of energy over strength training. And so some important compensatory swallow maneuvers that are used. The double swallow for each swallow of food. So you swallow once and then before you eat again, you swallow again for each swallow. A chin tuck maneuver. Small sips and bites alternating with that liquid, and the liquid used to wash down those residuals. And then diet modifications, which we'll talk about in just a bit. And then pre-meal lung volume recruitment, which Dr. Wolff spoke very eloquently about. So the diet modifications for people with difficult swallow but without penetration or loss of weight would be texture modifications, mincing, mashing, and pureeing. And then people who have consistent shallow penetration, accumulation of residuals but without aspiration would be puree consistencies and drinking water during and after meals. Thickening, if it's appropriate, of the liquids, and then small calorie-rich and frequent meals with water during and after. And the key is those small calorie-rich meals frequently is that you take away some of that fatigue from those big meals. So shifting gears a little bit from the swallowing and going to another not-so-favorite topic, ventilation. Why is ventilation such an important topic? So if you look at the survival curve of Duchenne muscular dystrophy, there is really probably not another intervention that has made such a profound impact on the lifespan of patients with Duchenne muscular dystrophy. If you look at the curve of survival in these patients, it is profound what ventilation has done. It has more than doubled the lifespans of these patients. And so though it is not a favorite intervention for patients with Duchenne muscular dystrophy, and I have lots of sighs and eye rolls and sometimes anger when I bring up these interventions for our patients. It is a very, very important intervention, and it can make a huge impact both in quality and survival. So non-invasive ventilation. Now, when I created this talk, I did not go in depth into these interventions. So what am I talking about? BiPAP and the sip and puff. The reason I didn't go in depth into when and what these are is because this topic was covered very well, very eloquently, in great detail in the Part 3 Adult Care presentation done by Dr. Wolff and Dr. Sheehan in this PPMD 2014 webinar series. And you can find it archived on the PPMD website, and it is a wonderful watch. And so I recommend anybody who wants more information on it to go to the PPMD site and go look at it. Like I said, it's the Part 3 Adult Care 2014 presentation by Dr. Wolff and Dr. Sheehan. They do a beautiful job of covering this information, and I thought it would just be a waste of time for me to recover the exact same material, so I decided to extend on it a little bit and cover some different material within this topic. But for more information on that, please do go back and look at that. So for non-invasive ventilation, what are we talking about? BiPAP and sip and puff. So what BiPAP is it's two pressure setting ventilation. So the IPAP is your inspiratory or inhalation pressure. It's a high pressure for when you breathe in, and it helps you take a big breath. So patients with Duchenne muscular dystrophy has a muscle weakness that stops them from being able to take those big, deep breaths. This setting is what helps augment that. It helps take that big, deep breath, that breath that they can't take by themselves. So that's what the IPAP is. The EPAP is your expiratory or exhalation pressure. It's a low pressure setting for when you breathe out that helps keep your airways open. So it's low enough where it's not hard to exhale against, but it's a pressure setting that helps keep the airway open. Sip and puff is mouthpiece intermittent positive pressure ventilation. So the straw you use to sip on, so that's where the sip comes from, and then the negative pressure that is created from the sip triggers the ventilator to give you a set breath for the puff. So hence the name sip and puff. The ventilator usually set to a patient comfort around an average tidal volume, so your breath size, and an I time, which is the time in which that breath is given. So basically what I tell my patients when I order them sip and puff is, all right, I am writing sip and puff set to patient's comfort. And our respiratory therapy durable medical equipment companies come out and they set it to the patient's comfort. So I tell my patients, I'm like, you be picky. You tell the equipment company and the respiratory therapist what you want, the big breath you want, the speed at which you want it to. And then when you want it, you take a sip on that straw and you get that breath. And that's where you want it. And then in a week, if you decide, I don't like it, it's not big enough, or it's coming too fast, then we'll call them back out and we'll adjust it to you. And that's the glory of sip and puff. When is this needed? So most patients start to take breaks during the daytime using their nighttime BiPAP, or they start going on their BiPAP earlier as the first transition. So most of my patients come into clinic and they say that I've been doing it during the day because I need a rest, or I'm going on a few hours before I go to bed because I'm just feeling tired. So this is something that patients do by themselves, most often on their own, because they know that they need it. You guys are smart. You know what you need. And so symptoms otherwise for indication of needing this are daytime fatigue, dyspnea, which means you're feeling short of breath, difficulty concentrating, or headaches. When is it needed from an objective indicator? So what are the numbers that we as pulmonologists are looking at? So daytime oxygen saturation is less than 95%. Carbon dioxide levels, so that carbon dioxide, you're not getting rid of that ventilatory effect, over 45 millimeters of mercury. And these two numbers are despite nocturnal ventilation, so despite using BiPAP. And then, of course, vital capacity, so that spirometry number of less than 680 mLs or 15 to 20% of predicted for your height, age, and gender. So in the great literature, the scarlet letter is A, for adultery. And I find in the pulmonary world, it's T for tracheostomy. The pulmonologist who brings up the tracheostomy word usually then has to wear the T and is the ostracized pulmonologist, because this is the most hated topic. And the person who is then the ostracized person for having brought it up, at least it is within our center. And so what are we talking about? So when the tracheostomy is brought up to a patient with Duchenne muscular dystrophy or any neuromuscular disorder, we're talking about a tracheostomy to be placed for full ventilatory support via the tracheostomy tube. And most often this is 24 hours a day, but it does not have to be. Sometimes there's breaks in between there, but most of the time that's what that transition is for, and by the time that is brought up. And it can be a single setting, but sometimes patients will have separate day and night settings. The most important thing that I have to say about this is, when is it needed? Patient preference, 100%. Even if the other criteria below this are met, even if there is a life-threatening event, even if there's anything, whatever it is 100% patient preference. Someone never, and in no way, shape, or form does anyone have to choose a tracheostomy and invasive ventilation, so a ventilator and trach. it is 100% patient preference. This does not have to be a life choice for someone. And so you can meet all the criteria for it and not choose that path. It is 100% a patient's preference. So I ask all my patients early to start thinking about it and what is best for them in their life. And that is the right choice for them. But if it is something that they choose to do, what do we consider the criteria or when someone would start needing that? So the inability to use non-invasive ventilation for whatever reason, either it's not working for them or they're not tolerating it. 3 failed extubations, or times to pull out the ability to pull out an endotracheal tube, so a mouth breathing tube during a critical illness despite optimizing use of non-invasive ventilation, and cough assist, and life-threatening respiratory event. So when we were creating this talk, Dr. Wolff and Kathy Knick we thought it'd be a really great idea to bring up the frequently asked tracheostomy questions. So the things that we're asked or that we think that the patients are thinking about or talking about or we know and we hear about later that they were looking at the internet, or the things that they were afraid about that they didn't ask us. Now, by no means does this talk about all of them, but it is the ones that we hear about. So, does a tracheostomy cause or worsen swallow dysfunction? So these are 2 of many, many studies that looked at that. And basically, the 12 patients who aspirated before trach, aspirated after. 7 of the 8 patients who did not aspirate before trach did not aspirate after. And then the study looking at cuffs did find that cuff up did significantly affect aspiration. And so basically the answer is it seems to be more dependent on the cuff and on the individual. And at our center and many centers, it is recommended that cuffs be down to assist in swallowing with a tracheostomy, and that if there are issues with the patient's swallow, that you do swallow studies and look at it afterwards. But most of our patients who can swallow before a trach can swallow after a trach. Does a tracheostomy prevent aspiration? Absolutely not. And I do tell my residents this all the time too. No. A cuff is below the vocal cords, and so if liquid is getting down there, then you are already aspirating, and it does not block the entire airway, and liquids can get past it or around it. It does provide a more direct route for suctioning if you do aspirate, and so it can help make an aspiration a little less severe, theoretically, but you are still aspirating. Can I talk with a tracheostomy? Absolutely. Many of my patients can whisper without a valve secondary to air leak around the trach, but to talk with a voice, we use what's called a passing mirror valve, and those are some pictures right there. And so on the left is no passing mirror valve. You can see the air from your lungs comes up and out the hole of the tracheostomy tube. But once the passing mirror valve is put onto the trach, the air will go up past the tracheostomy and it's forced up around the tracheostomy tube, up through the vocal cords and out through the mouth, thus creating a voice. Can I be active with a tracheostomy? 100%, it is the expectation in our center that you are going to be active and up and about, and this is a perfect picture as a representation. This patient is trached and vented, and they are participating in the Power Wheelchair Soccer World Cup. So it is 100% the expectation, and the answer of myself and my other colleague who does adult neuromuscular pulmonary care is you better be active or else you're going to hear from us. So what kind of infections can I get with a tracheostomy? So stomal infections, so that's the area around the trach, so treated with topical antibiotics. Tracheobronchitis is one of the most common. This is the main airway of the trachea and the first branches of the lungs, the bronchi. So it's the most common infection. A study done at my center, we have one of the largest trach vent populations in the nation. It was done on 225 patients over 69,000 trach days. 60% had one or more of these in a year. It was 1.28 tracheobronchitis episodes per patient per year. And they're usually treated with inhaled or enteral, so systemic or in your stomach intestine antibiotic. You can also get a typical cold. You can get pneumonias, viruses, bacterial or aspiration pneumonia. And then an advantage actually of being on the ventilator is that some increases to the settings potentially can be made to help keep you at home. Most of our patients have a protocol where we can increase the vent settings. They have sick and well settings. So we can, our goal is always to keep them at home when they're sick as best as we can. It's always up to the comfort level of you and your care team. And then some of our patients actually get less pneumonias and less sick once they're ventilated because they're actually breathing better because we've improved a hypoventilation state that they had before getting the tracheostomy placed. Can I live independently with the tracheostomy? This is our last and most important question. The general rule is those who have an artificial airway in who cannot remove it themselves need to have an awake individual with them 24 hours a day. So basically you need someone for suctioning, manipulation of the airway. If it gets plugged, blocked, dislodged, or if your ventilator gets disconnected or it malfunctions, etc. The way I describe it to my patients is if you can that I want you to live your life doing what you want, but you just need a buddy around to help keep your airway clear and functioning. So that's how I tell everybody that that's what it means when you get a trach and vent, is that I still want you living your life. You're just going to have a buddy around with you. That's it. Thank you very much. Thanks to PPMD and everybody. And I think this leads to question time.
Thank you so much to both of you. This was really important, really fascinating information. And again, as Christina said, we're not encouraging tracheostomies, but we knew that there were a lot of questions out there around them, and we wanted to give Christina and Lisa an opportunity to answer some of those questions. Christina, could you talk just for a minute about what exactly aspiration pneumonia is and why drinking after a meal is important? And if anyone else has questions, if you can type them in the box, that would be great.
Sure. So aspiration pneumonia is when either oral contents, so your saliva with the salivary enzymes or your bacteria in your mouth, and that contents get down into your lungs, or actual food particles get into your lungs, and then that bacteria and inflammation set up an infection. So if it just causes inflammation, that's an aspiration pneumonitis. And then if it causes an infection, it's an aspiration pneumonia. Now, it can happen actively while you're eating and in that process, or if you have residual, so what I talked about earlier where that food gets stuck in that upper airway portion and doesn't actually get aspirated, but they sit there, and then later on, even hours afterwards, those get dislodged and then go into your airway because they've been sitting there and they can be aspirated down into your airway. Even hours later, they then can set up shop and set up an aspiration pneumonia even later. So it's very important that those residuals get cleared while you're eating and in that process because of that dislodgement and getting those stuck into your airway. They can actually cause life-threatening events if they're large enough deposits that go in and block up an airway. And so it's important during the swallowing process for those residuals to get cleared. And so if you are safely swallowing liquids, which those swallow studies are very important to make sure that you're swallowing both solids and liquids safely, that they use the use of liquids to help wash down any of those residuals and deposits and those thicker foods that may be harder to swallow, to wash everything down and make sure that your entire upper swallow larynx, so the upper hypopharynx, the supraglottis, your laryngeal area, and everywhere and everything is completely cleared, and you get it all down your esophagus and everywhere that it's supposed to go, so everything is cleared so you do not have any issues with aspiration and the development of pneumonia.
Thanks. That's really clear. Is there a correlation between dental care and pneumonia risk?
There is a huge correlation with dental care. So clean mouth, appropriate dental care decreases the bacterial burden in our mouth, and the lower the bacterial burden, the lower risk of aspiration pneumonias because it decreases the amount of that bacteria in the aspiration. We all actually aspirate some in our sleep, everybody. And if you have an at-risk swallow as it is, you increase those aspiration amounts. And so if you have a higher bacterial burden, that means you are that much more at risk. And so it is very important to have great oral hygiene to decrease that risk of pneumonia.
Thanks. Lisa, could you talk about what an arterial blood gas is and if there are values in ABGs that indicate a time for sip and puff?
Yeah, so what happens is when your lungs have a big breath in, we all know that it's there to bring oxygen in, but sometimes we forget that the other job of a lung is to get carbon dioxide, which is the waste product of breathing, out of your system. And if your breaths are not big enough, frequently the CO2 can collect, and if it gets high enough, it can even make you unconscious. So it really can be life-threatening. A blood gas test is a blood test that gets blood from the artery rather than the vein, usually at the wrist, and that can directly measure carbon dioxide as it's coming out of the blood from the lung. So it gives you a better idea of whether or not there's effective ventilation. Our goal is to try and prevent CO2 from going up. So the first thing that we do is to do non-invasive ventilation at night. But if we find that people are having either more difficulty with breathing during the day or that the CO2 is starting to climb during the day, then we initiate daytime support to help rinse that out. Daytime support non-invasively is most often done intermittent. Sometimes we do that with mask ventilation, say 1 to 2 hour breaks during the day. But more successfully, especially in Duchenne muscular dystrophy, is the use of a mouthpiece that can be intermittently sipped on or a big breath taken every few minutes to assist with breathing, with cough, with helping to be more clearly understood, to help with swallow. And these persistent increased breaths during the daytime also helps to rinse out the CO2 effectively and prevent it from rising during the day.
Thank you so much. That's really clear. Christina, what kind of training is needed for a person who is a buddy for a patient that has a trach and needs to be with that person for 24/7? Would it have to be a nurse, or can anybody be trained?
So anybody who is caring one-on-one for a person who has a tracheostomy and who is on a ventilator has to receive special training with tracheostomy and ventilator training from a respiratory therapist in a hospital, so prior to training or prior to taking care of that person. They do not have to be a nurse, so family members are trained, but they have to have that special training and be kind of passed off or cleared to take care of the person. And the purpose is to take care of these life-threatening events. So if they have to change the trach, if they have to troubleshoot the ventilator, if they have to take care of emergency situations. There is a nationwide nursing shortage, and so many family members are doing hours during the day taking care of our patients who are trached and vented. And so by all means, it does not have to be a nurse, and is often brothers and sisters and moms and dads and cousins and but they absolutely have to have full training on trach and vent with professionals beforehand.
Okay, thanks. Lisa, we know that acid reflux is often a problem for people with Duchenne, especially if they're on steroids. So could you talk just a minute about microaspiration with acid reflux and how you would recommend that patients deal with that?
Yeah, there's some key things that you can do to help prevent pneumonia. And like I said, prevention of pneumonia is one of the key activities a pulmonologist is going to work with you on. The first thing is when sleeping, we recommend that the head of the bed be raised to about 30 to 35 degrees to help prevent any reflux episodes from landing in the lung. In addition, we recommend that you finish eating 2 hours before going to bed, because the less you have in your stomach, the less likely you are to have reflux. During the daytime, we also recommend that you stay upright after meals to help prevent episodes. In addition, we want you to take a clear notice of what's going on with your bowel movements. Patients who have significant constipation issues, have a bloated stomach, are more likely to aspirate. And if you notice that with the use of your non-invasive ventilation, you're feeling bloated or like there's more air in your stomach, you need to talk to your pulmonary provider so that changes can be made, because if there's too much air bloating in the stomach, it can force you to have more aspiration events.
Thank you. And last question, Christina, we didn't think about this one. Can you brush the teeth of somebody who has a trach?
Yes, you can do regular dental cares and regular dental visits, although there are specialized dentists who can accommodate patients who are in power chairs, and so that's important to ask prior to going to a dental visit. There are specialized dental care equipment and toothbrushes that for patients who have swallow dysfunction that can be hooked up to suction. So if someone cannot have certain consistencies like thin liquids or that in their mouth because of aspiration, there are specialized brushes and equipment that can be hooked up to suction to accommodate this, and there are specialized toothpaste that are also specialized for dental cares for people who also are not taking consistencies by mouth. If it has also come to that, to decrease bacterial burdens within the mouth, to decrease aspiration pneumonia risk because of the bacterial overload in the mouth and the changing flora because of not taking oral contents by mouth. And so there are lots of different options as well.
And this is Lisa Wolff. I just wanted to add to that. One of the challenges that we have is that the most commonly used toothbrush that can be adapted for suction is made by a company called Sage. They're called Sage kits. Sage kits, for whatever reason, can be difficult to find in regular pharmacies and medical supply stores. So we recommend either talking to your pharmacist about whether they can order them in for you, especially at a medical supply shop, or there are lots of online sites, and we would recommend looking online for those.
Also, thank you so much.
The only other thing I was going to say is the special toothpaste should have chlorhexidine in it. Chlorhexidine toothpaste also can be very challenging to find on an outpatient basis, and so they do make a mouthwash called Paradex, and that can be used on a sponge to go down into the gums and really kill that bacteria that causes pneumonia.
Thanks. So dental hygiene and regular dental appointments, dental care are very important for not only your teeth but also your lungs. So don't neglect that. I'd like to thank Christina for raising awareness of our pulmonary awareness series that was recorded in 2014. And as she said, those videos are available online. I'd also like to thank Santhera for their support of our recently released pulmonary whiteboard videos, which is a series of 5 videos that can help you understand pulmonary care, the need for pulmonary care, and some of the procedures and abbreviations that are involved in pulmonary care. So thank you so much. For everyone in our audience, if you haven't already, please update your pulmonary module in Duchenne Connect in the registry. And with that, I would like to thank both Lisa and Christina for this fascinating webinar. It's been extremely important, and I hope that all of you understand pulmonary care a little bit better. Thank you so much.
Thank you.
Thank you so much.